Hello, my name is Margaret Schermerhorn, and I'm a medical student at Rush University Medical Center in Chicago, Illinois, in the United States. And I'm pleased to be here today to present on behalf of my research team and talk to you about the impact of inequities on delay in breast cancer management and women undergoing second opinions. So let's get started. Breast cancer is the second leading cause of cancer-related death in the United States, and breast cancer outcomes have been well studied, with many studies showing that delays in breast cancer treatment lead to poor outcomes. These poor outcomes, more specifically, as you can see here, include poor treatment response, decreased survival rates, and lower quality of life. And previous disparities research demonstrates that disparities exist in breast cancer management in general, and including treatment delays as well. And patients with certain demographic and clinical characteristics experience longer treatment delays than others. For example, Black patients experience longer treatment delays and lower survival rates when compared to white patients. And it should be noted that these disparities in breast cancer outcomes and treatment delays exist despite major advancements in breast cancer management over the last 30 years. And so this suggests that developments in treatment do not always benefit all women in an equitable manner. Factors that impact these delays have also been studied and are potential contributors to disparities in treatment delays. So in our literature review, some common factors that impact treatment delays that we found you can see here are language, financial status, insurance status, and ethnicity. Other factors that might contribute that are still unclear include education, cultural and religious beliefs, communication, and patient-provider relationships. And so while these factors that have been shown to contribute to treatment delays have been relatively well studied in breast cancer patients, very few studies have looked at specifically the experience of patients seeking second opinions. And so we found that or thought that this was a really important patient population to study. And so that's kind of the patient population that we focused on for this study. And we hypothesized that the factors above here, so language, financial status, insurance status, and ethnicity, contribute to treatment delays at our institution. And our goal was to identify which of these factors had an impact at our institution and specifically had an impact on this niche, yet very important patient population. And so for our materials and methods, we conducted a retrospective chart review of patients presenting to a single academic medical center seeking second opinions for breast imaging, breast diagnosis, or other breast-related complaints between January 2017 and July 2019. You can see that listed here. And then within that subset of patients, we had some exclusion and inclusion criteria. Patients included were over the age of 18 and had stage 1 through 3 breast cancer diagnosis and were ultimately treated at our institution. For exclusion criteria, we excluded stage 4 breast cancer patients, and then we also excluded those patients who were not treated at our institution. Our reasons for this was that we wanted all patients to be surgery eligible. And stage 4 breast cancer patients are not always eligible for surgical treatment. And so we did not want to include them because we wanted all of our patients to be eligible for surgery. And then for those not treated at our institution, because we're looking at time to treatment and time of different intervals throughout the treatment course, we wanted to be sure that we could follow these patients. And so if they came to our institution and were treated elsewhere, they were not included. The study variables that we included based off of our literature review in the slide before were race, ethnicity, age, income, insurance status, type of surgery, and tumor stage. And the time points of interest in the treatment course were listed below. Our first initial time point that we wanted to look at was the date of diagnosis. The following two time points, IOE stands for interpretation of outside examination. And so we wanted to know when that was ordered, and then when that was completed. The interpretation of outside examination is essentially the paperwork required for patients to be seen at this institution for second opinions. Following that paperwork, we wanted to know the date of the initial encounter as well as the date of initial treatment. Once all of these variables and time points were collected, a Kruskal-Wallis test was used for the univariate analysis to assess the impact of these study variables on time intervals indicated below. Then multivariable binomial regression was used to evaluate the impact of study variables on time to treatment using adjusted incidence rate ratios. And so for our results, I know there's a lot of results here. I just wanted you all to be able to see all of it, but I will walk you through it. Just for our patients and their demographics and what they looked like, a total of 307 patients met inclusion criteria. Of these 307, 239 underwent surgery for their initial treatment, 63 received neoadjuvant chemotherapy, and 5 were not included because they underwent a gynecological surgery for their first treatment, and there weren't enough patients to do a significant analysis on these patients, and so we ended up with a total of 302 patients. In terms of our univariate results, race did seem to have an impact on treatment delays. The average time from diagnosis to surgery for Black women was 56 days, for Latina women was 49 days, for Asian women was 45 days, and for white women was 42 days. And so the difference, especially between white women and Black women, 42 days for white women and 56 days for Black women, is a stark difference, and kind of goes along with what we had seen in previous literature. But we kind of wanted to get into that, and so we did a multivariable analysis, and these are the results that you can see here. And so as you can see, we looked specifically at the time from diagnosis to surgery and then the time from initial encounter at this institution to surgery. The variables you can see all the way to the left. And if you recall, the variables that we had seen were most significant in the literature before this study were language, income, race and ethnicity, and insurance status. We were not able to assess language. It wasn't very well reported, and so we didn't include it in our analysis. But all the other variables that I had mentioned earlier are here, along with some others as well. And so as you can see, age did not have significant impact on treatment delays, regardless of whether we were looking at the diagnosis to surgery or the time from initial encounter to surgery. So age was not a significant factor. However, income was a significant factor. Patients of low income were more likely to experience treatment delays than patients of any other income bracket. And this is both delays in diagnosis to surgery as well as delays from initial encounter to surgery. As well, race and ethnicity were significant. Here, the biggest significance and really the only significant result we found was Black patients experienced longer delays in treatment longer delays from diagnosis to surgery. However, looking just at initial encounter at this institution to surgery, that disparity went away. And so kind of pointing to the fact that the delay might be before the patients got to this institution, which I'll get to in a second. But really focusing on the fact that the main delay or the main factor for race and ethnicity is looking at Black patients experiencing longer delays from diagnosis to surgery overall. Alternatively, cancer stage 1, 2, or 3 did not appear to have a significant impact on a patient's treatment delays. And then for insurance, those patients with managed care were the only ones with a significant increase in risk of delay, and specifically an increased delay from initial encounter to surgery. But this was not seen overall in in diagnosis to surgery. Finally, the type of surgery does matter and play a role in the delays that patients experience. Those who underwent mastectomy for their treatment, total mastectomy that is, experienced longer delays in treatment than those undergoing a partial mastectomy. And this was true for both diagnosis to surgery as well as initial encounter to surgery. On the contrary, whether or not a patient received reconstruction during the surgery did not have a significant result or a significant impact on delays in treatment from diagnosis to surgery or from initial encounter to surgery. Here are results, again, multivariable analysis for the time from diagnosis to chemotherapy and initial encounter to chemotherapy. Again, 63 of our patients kind of fell into this bucket, so less than those who received surgery as their initial treatment. But here you can see that race and ethnicity really was the only factor that had an impact on treatment delays for patients undergoing chemotherapy for their initial treatment. You can see that Hispanic women had a higher incidence of treatment delays from initial encounter to chemotherapy. This delay was not seen when looking at the whole timeline of diagnosis to chemotherapy. Other races, Asian, Black, and other, when compared to the white race, did not have significant increases in delay, again, when compared to the white race. All other factors that we looked at, age, income, stage, and insurance, did not appear to have an impact on delays from diagnosis to chemotherapy or initial encounter to chemotherapy. And so in terms of discussion, what does all of this mean? And so we found that our results were in line with much of the existing research, and that race and ethnicity do seem to affect time to breast cancer treatment. Few studies, however, like I mentioned before, have looked at patients undergoing second opinions. And so the goal of the study was to identify factors that led to treatment delays for patients seeking second opinions, again, at this single academic center. And we identified several of these inequities in treatment of this specific patient population that weren't otherwise documented in the literature before. As I noted on the previous slides, Black patients experienced longer time from diagnosis to surgery than white patients. And we think that this could be attributed to factors that weren't captured in our study. For example, comorbidities could play a role here, and we weren't able to look at comorbidities in this study, and so that might be something that could be playing a role and that we'd like to tease out in the future. Additionally, Black patients are more likely and have a higher incidence of triple negative breast cancers and biologically aggressive breast cancers. And so this could very well play a role in these treatment delays that we saw. And so again, further studies to kind of parse this out would be good and helpful to get down to what is really causing these delays. We did also note that race was not a significant factor from the time of initial encounter to surgery, which suggests that the delay is most significant before presentation at this academic medical center. And so this means that kind of targeting those patients who are more likely to experience delays and really working with them before they get to our medical center would help the most in decreasing those treatment delays. Again, as I mentioned earlier, patients receiving surgery experienced more delays in general than those getting adjuvant chemotherapy as their first treatment. And this can be explained by, we think, of many explanations, including just any additional imaging that might be required before surgery, surgical scheduling, OR availability, involvement of plastics or other surgical teams, and potentially a financial burden could all contribute to a longer delay for patients undergoing surgery for their initial treatment rather than chemotherapy. Again, with the no delay and the lack of delay in whether or not patients underwent reconstruction, reconstruction did not contribute to the delay that patients experience. And so this was promising. It shows that there is improved communication and coordination between surgical departments and plastics teams, which is a positive for patients for sure. We don't want, getting reconstruction to be a risk factor for experiencing treatment delays. Again, as I mentioned before, in terms of chemotherapy, Hispanic patients did experience longer delays to neoadjuvant chemotherapy than white patients did. Again, this is likely attributable to factors not studied in this study. Could be anything from, again, comorbidities that we mentioned before to delay in obtaining records, things like that. Our study did have some limitations. The exclusion of stage 4 patients is a limitation for sure. We, as I mentioned, excluded these patients because we wanted all patients to be surgery eligible. And so that's why we excluded them. But patients with stage 4 cancer likely do experience treatment delays that could contribute to our results. And so excluding them might mitigate some of the results that we saw. And so it would be a good idea to include them in the future as well. Again, not collecting hormone status is another limitation to the study, as I mentioned, especially with those patients, Black patients who experience delays to surgery, and Black patients being more likely to experience triple negative breast cancer and biologically active breast cancers. Hormone status is a really important factor in all breast cancer treatment, and so could be contributing to this delay and many of the other delays as well. But with all of that, I want to move to conclusion and some next steps. As I've alluded to in this whole talk, delay in breast cancer management really is multifactorial. And there are many factors that each patient experiences that could play into their treatment experience. And so it's hard to nail down just one thing that attributes to treatment delays. But these delays still exist. And despite the necessity of equitable care, disparities do exist, and are definitely things that should be addressed, again, with our whole goal of providing equitable treatment for all patients with breast cancer. This is a good place to start with that. And so for our next steps, we hope to determine why certain patient demographics and clinical presentation characteristics continue to experience and continue to experience these delays. And so kind of maybe addressing some of the limitations I mentioned before, or further studies, getting into hormone status and other factors, education, language that have been cited before, that might be playing a role in these treatment delays as well. Currently, we're working on a future study, and it's an ongoing study of all breast cancer patients treated at this institution. And so this study really helped us identify some factors that are present at our institution that contribute to treatment delays. And so we want to see how this data plays out with all patients at our institution. Again, specifically, we were really interested in the fact that with the delays in surgery, most of the delay was experienced before the patient was seen at our institution. And so we're interested to see how a patient's experience might be different, or how factors might play in differently for patients who are both diagnosed and treated at our institution. So more information we're hoping to come from that. And our goal, with all of this disparities research is to implement system level strategies and to address the inequities in breast cancer treatment. The reason we wanted to identify these factors is because it kind of shines a light on the patient populations who are at a higher risk of experiencing treatment delays. And as the literature has shown, again, treatment delays contribute to poor outcomes. And so if we have a group of patients that we know is at a higher risk of these treatment delays and therefore poor outcomes, we can, jump in on their care earlier and make sure that they're not falling through the cracks or experiencing treatment delays that can maybe be prevented. And so that's our goal with all of this disparities research, and hopefully providing more equitable care for breast cancer patients at this institution and elsewhere as well. But that is all I have, and open to any questions. Thank you again for the opportunity to present and participate.